This is going to cover some of the major causes of hypertension. We're going to talk about exactly what hypertension is, and I'm going to break it down between adults and children. And so there are these four classes whenever you classify a blood pressure. It can be normal, prehypertensive, stage 1 hypertension, or stage 2 hypertension. And what you want to do is remember for diastolic, you want to remember 80, 90, 100. And for systolic, you want to remember 120, 140, 160. So let's talk about normal blood pressure really quick. If systolic is less than 120 and diastolic is less than 80, you're normal. And then prehypertensive, we're going to say that 120 is less than or equal to, systolic is less than or equal to 139. Or I could have just put the less than sign and put 140, so that's the key number there. And for the diastolic pressure, we're going to say that 80 is less than or equal to, the diastolic is less than 90. So for stage 1 hypertension, we're going to say that, so we take our 140, so we say that 140 is less than or equal to, systolic is less than 160. And then for diastolic, we say that 90 is less than or equal to, the diastolic is less than 100. Then for stage 2 hypertension, the systolic is greater than or equal to 160, or the diastolic is greater than or equal to 100. And so these are the requirements set by the powers that be on the definitions of the and classification of hypertension. Now it's important to note clinically, now not as a hard fact, but clinically, anyone that's taking drugs to treat hypertension, consider them hypertensive unless you know for sure that the cause of their hypertension has been corrected. So even though their blood pressure won't match these up here, they'll be normal blood pressure, you're going to say, for all practical purposes, these patients are hypertensive. We're just treating them and making sure that their blood pressure doesn't go into hypertension. And like I said, if we could just memorize these numbers, the 80, 90, 100, 120, 140, 160, this becomes really quick. So we would say, we'll just put our numbers 80, 90, 100, and I'll put normal. Then I'll put prehypertensive, hypertensive 1, and hypertensive 2. And that's for my diastolic. And then for the systolic, I'll put 120, 140, 160. And this would be normal. This would be prehypertensive. This would be hypertensive stage 1. And this would be hypertension stage 2. There are two more classifications of blood pressure that have to be talked about when you talk about hypertension. There's hypertensive urgency and hypertensive emergency. Just wait and see. These two classifications are classified based on the diastolic pressure alone. In adults and children, it's a little bit different, as you're going to see. So both of them, you'll say if the diastolic is over 120, it has the potential to be an emergency. It already is going to be urgency. It has the potential to be emergency. So urgency, emergency, both have a diastolic greater than 120. The difference is with the urgency, it is asymptomatic. With emergency, it's evidence of organ failure or damage. So that could be a lot of things. So you could have retinopathies. So let me actually change that to pencil. Retinopathy. You can have renal failure, renal disease, where the glomerulus is being damaged. There can be cardiac remodeling, so the heart is changing its size and shape and strength. And what plays into that is heart failure. You can also have neurological events where there's too much pressure on the brain. And so with this, the main things you're going to look for: renal, neuro, and cardio. So what's the differential diagnosis? When you have a high blood pressure, you just have to ask yourself what factors control blood pressure. That's cardiac output and systemic vascular resistance. So anything that changes cardiac output or the vascular resistance is going to increase the blood pressure. Now we know that the cardiac output is equal to the heart rate times the stroke volume. And so you can actually substitute this into this equation right here. So you get that the blood pressure is equal to the heart rate times the stroke volume times the systemic vascular resistance. So let's think about, for example, stress. Stress will release catecholamines, which will increase both the heart rate and the stroke volume. It can even have some effect on the resistance of the arteries. What about if your kidneys fail? Well, if your kidneys fail, you're going to have increased preload because you're not going to be excreting water, so you're going to be hypervolemic. You're going to have an increased preload on your heart, and so it's going to increase the stroke volume. And so anything that we could think of that would change the blood pressure is something that affects one of these things. And that's going to drive our differential. Now, there's two primary categories for hypertension. You have primary or you can have secondary. Primary meaning we really don't know what causes it. However, the theory is that it's a combination of genetics and environment. So environment. And the reason that we can say those things is because of the risk factors associated with it. So I'll finish writing environment. Now, the secondary is where we can identify a specific cause for the high blood pressure. Now, in older adults, primary is more common, and in children and adolescents, secondary causes of blood pressure are the primary reason for reporting. So things that support this genetic and environmental cause. So first of all, the family history of having a high blood pressure will increase your chances of also having a high blood pressure. I'm not going to read these to you. I'm just going to point out a few of the interesting things. You can look these up in the study guide I've posted if you want them. So reduced number of nephrons, like this, that sounds crazy, but I guess some people have kidneys. On average, the textbooks say each kidney has 1 million nephrons, so you have 2 million nephrons in your body. But I guess that's subject to genetic variation. And we're talking about primary hypertension now, so we're not talking about kidney damage and they lost some of the working nephrons. No, we're talking about primary, so we haven't identified a kidney pathology, except that we have a kidney that didn't make enough nephrons. Excess of alcohol and inactivity. All of the guys in the room right now are making a mental note to take their blood pressure when they get home. You know who you are. Another one that was really interesting is that being crazy actually causes a risk for hypertension. And so if you are impatient, have anxiety or depression, so just being crazy in general, and right now every female in the room is taking a mental note to check their blood pressure. And you guys know I'm only tongue-in-cheek right now. Just wait till I get serious. So now what about secondary hypertension? The first thing that you want to take care to realize is that it may coexist with primary hypertension. So you may say, oh, you have kidney damage, and so you have glomerulonephritis, and that explains, okay, this is why you have a hypertension. But then when you go in and fix everything, the hypertension doesn't go away. The reason I explained by is may have been a primary hypertension that coexisted with the secondary. Now, if there's one thing I learned in medical school, it's that anytime there's chest pain and hypertension, you always want to have cocaine on your differential. Now, of course, methamphetamine goes along with that. And then thinking backwards from that, over-the-counter drugs. Well, what do you make? What's one way to make methamphetamine? It's with cough syrup. So over-the-counter drugs, and there's many different types of over-the-counter drugs and other types of sympathomimetics. Caffeine being one, for example. Now, speaking of caffeine, I'll just say that caffeine is mystery to me. Why is it a mystery to me? Well, because we know that caffeine increases the heart rate, right? It may even increase the contractility a little bit. So I'll mention why contractility. Because we said that the blood pressure is equal to the cardiac output, which is heart rate times stroke volume times the resistance. Stroke volume is dependent on preload and on contractility, right? But here's the thing, caffeine is a diuretic, so you're going to lose fluid volume and decrease preload. So although the caffeine may increase your blood pressure some, it's not going to increase it as much as it would have if it wasn't also causing volume loss. And just my personal theory, don't use this to treat anybody unless you read some actual study on it, but my theory is that if your high blood pressure is due primarily to hypervolemia, so hypervolemia, too much volume, then I think that this could be treated with caffeine. Treating blood pressure with caffeine, that's my theory. I mean, in clinical practice, there are 100 better diuretics. So no one's probably actually ever going to try this out. So I think as far as being proved wrong, my theory is probably safe. Okay, let's go back and get back to what the discussion was about in the first place, which is other causes of hypertension. And again, I really don't see any other interesting things on here that just jump out to me. These are all pretty standard things that you can look at. One thing I did see in the reading, and I didn't look up the pathophysiology, is that both hypo and hyperthyroidism could cause an increased blood pressure. Seems counterintuitive. You got hyperthyroidism, and it's causing a high blood pressure. You treat it, and you cause hypothyroidism, and your blood pressure is still high. It just seems counterintuitive to me. So I think probably a little bit more is going on than what meets the surface. Now let's talk about hypertension in children. So the numbers you're going to remember now are 90, 95, and 99 plus 5. So the way that hypertension is defined for children is based on sex and the age-height charts. And I'm actually going to show you that here in a second. So someone is considered normal if their blood pressure is less than the 90th percentile for their sex, age, and height. Now, prehypertensive is the tricky one because it is defined one of two ways. So you can define it as greater than 120/80, and that's the way we also define adults for prehypertensive. Or you can define it as the 90th percentile is less than or equal to the systolic or diastolic. So in children we use systolic and diastolic at the same time, and that is less than, not equal to, but just less than the 95th percentile. So if either the systolic or the diastolic or both are in this range, then they are prehypertensive. And so then the next thing we have is the hypertension stage 1, and we're going to define that as the 95th percentile is less than or equal to the systolic, or the diastolic is less than the 99th percentile, so the 99th percentile plus 5 millimeters of mercury. So we're going to take whatever the 99th percentile is, whatever that blood pressure is for the age, sex, and height, we're going to add 5 millimeters of mercury, and that is going to be the upper limit for stage 1 hypertension. So whenever you get to 99 percentile plus 5 millimeters of mercury, that is going to be, if that's less than or equal to the systolic or diastolic, then you're at stage 2. And so what you'll have to do is you just write 90, 95, 99 plus 5. Put that in parentheses. Over here you're normal. Over here you're prehypertensive. Over here, you're stage 1, and right here, you're stage 2. Before we take a look at the charts that show the diastolic and systolic in the 90th, 95th, and 99th percentile, let's talk about the definition of urgency and emergency in children. This comes directly from up to date. It says that in children, hypertensive urgency is defined as severe increase in blood pressure without evidence of organ failure. Here's the problem. Nowhere in the whole thing does it give a definition of severe. I don't have a number, I don't have a percentile, I have nothing to say what severe is, so I don't know. I'm just going to say stage 2 hypertension. That's severe to me. I think that's severe. But here's the problem with that. Whenever it talks about the definition of hypertensive emergency, it says again severe elevation of blood pressure without evidence, with evidence of failure, and then it goes on to say that the percentile at which this happens is not clearly defined because it's different for different children and the different primary causes of the hypertension. So literally what this means to me is if a child has a elevated blood pressure, no matter what that is, if it's anywhere above normal, and I think that's causing a problem, then it's an emergency. Or if it's not causing a problem and it's above normal, and I feel like giving it a special urgent term, I'll call it an urgency. If anyone else has any other thoughts on that, let me know. So here's the chart I was telling you about. And over here on the left, and I only got this goes all the way down to age 17. And so you're considered a child or adolescent from the ages of 1 to 17. There's actually different requirements for infants from 0 to 1, but I didn't go through those. So what we have is the percent of height. So you look at their height chart for their age and you say, oh, this kid is at 25th percentile for his height. And then you measure the kid's blood pressure. Oh, you measured it at 101. So you follow that back over, and their blood pressure percentile is 95th percentile. This kid would be at the beginning stages of stage 1 hypertension. You can do the same thing for the same kid with his diastolic. So you remember that based on his height, he's in the 25th percentile. You measure his diastolic, it is 51. You follow that over, and it's in the 90th percentile. Does that mean that, maybe this kid is only pre-hypertensive? No, it doesn't mean that, because the definition for hypertensive means either the systolic or the diastolic are in the 95th or above percentile. Now let's take Junior, a 4-year-old, who is in the 75th percentile for his height. And so we're going to follow this down. He's 75th percentile. We're going to measure his blood pressure, and his blood pressure is at 122. So it's above the 99th percentile. But remember, in order to be stage 2 hypertensive, we take the blood pressure in the 99th percentile, which is 120. We add 5 millimeters of mercury to that and get 125. And he has to be greater than or equal to 125 to be stage 2. So clearly he's only stage 1. You got to remember, for kids that have hypertension, adolescents and children, they are mostly going to have secondary hypertension. So there's going to be another pathology to explain it. And these, the main ones would be renal disease, endocrine malfunction, neurologic, cardiovascular drugs, and miscellaneous. And I just read you a list. I feel stupid. Good news is we're going to go through this list a little bit deeper, because you got to go deep. So here's the renal diseases, and I've given you a list of the most common ones that can cause hypertension. Pause and read if you will. Endocrine, I've given you a list of the most common causes of hypertension with endocrine. Pause, read, write down if you want. Neurologic problems that can cause hypertension, especially in children. Pause it and read it. This is a short list because it's in children. Now, if we were talking about an infant, we might have a slightly different list, but this is children from 1 to 17. I kid you not, this list came from Up to Date, and it listed cocaine as primary causes of hypertension in children. I'm hoping those children are at least like 16 or 17. And how many kids are doing steroids? And then under miscellaneous causes of secondary hypertension, primary hypertension. And just in general, what kind of tests can we run? So suppose we wanted to see if there's some type of damage to organs caused by hypertension. So here are just a few that can be done. So the electrocardiogram, checking for cardiomyopathies. You can do the chest x-ray to the same vein. The urinalysis is going to check for kidney, and the serum creatinine are also going to check for kidney, but you can also check the cardiac enzymes. Get a light out and look inside the person's eye, check their retina. If that doesn't work, CT her brain. If you're thinking maybe an aortic dissection, you can do a transesophageal echocardiograph. That ends everything I have to say. Have a happy Thanksgiving, and I'll see you all on Monday.